So standards and certification, the first is just big picture, right? A few years back when I was in the market for an electronic health record for a large number of providers, there was some basic stuff that from a public health prevention quality perspective we expected to be in every electronic health record, things like decision support and quality measurement and registry functions, even consistent recording of smoking status, and it wasn't. Even though there were a huge, laundry list of very, very specific ways in which electronic health records had to meet particular CCHIT certification criteria, there were some fundamental things that weren't there. So I think the new certification process and the new certification criteria have really hewed to what matters. What do you really need in order to get to meaningful use? And meaningful use is really focused on what do you really need to do to improve quality, safety, and efficiency of care. So I think that's a big step forward. We also have seen that with competition in the certification program, with now 3 accredited testing and certification bodies, I think the level of service and the cost is going to improve as well. I think there's some early evidence that's already happening. In terms of the standards, we, I think, took a big step forward in terms of some of the vocabulary standards, having problem list, med list, smoking I mentioned, and some of the other kind of basic content standards set. For example, with medications at least, having them be mappable to RX norms. So whether you want to use First Data Bank or NDC, that's fine, but it's mappable to a system so that when we do share information, we can make steps towards understanding that information and sharing that information in a meaningful way. We also made, I think, a significant step forward in terms of coming up with some messaging formats, CCR or CCD, so that information could be transmitted and anybody could be able to receive, and at least in a human readable format, present either a CCR or a CCD and be able to produce one. Most importantly, so that patients can have this information for their own use and reuse. Do with it what you will. So I think
sort of like a blue button download for everyone.
So we'll talk about Blue Button later. Blue Button's fascinating, and it's been really, it's a great example of how you can get really viral adoption of technology if it's simple enough and it meets a need. But anyway, the one piece that we did not, so in terms of what's coming for standards, I think we need to continue to get deeper in terms of the vocabulary standards on some of the areas where we didn't have vocabulary standards. I think on the messaging side we need to get more to the implementation specification level. For example, on some of the public health, we didn't have syndromic surveillance, we didn't have any implementation specifications, and potentially even on the CCR or CCD to get more specific about how that is represented. But I think there's one piece which is transport that we were silent on in the final rule. And it is my hope that we will be able to evolve the NHIN Direct standard services and policies to the point where the Standards Committee could endorse them for meaningful for getting there. Chapel. So we have the version 1.0 of the Chapel out now. As you say, it collects from all the different ATCBs the products that they report to us. It's version 1.0, and version 2.0, which should come by the end of the year, will have things like better formatting, like this, having separation between the inpatient and the outpatient products, but also being able to drill down more, being able to multi-select different products and be able to say, do these cumulatively meet all the meaningful use criteria, and also being able to have transparency around which quality measures the product reports. I will say that we're going to make we have already started, and we're going to be making real progress in terms of standardization on the public health side. There's funding that we put out. The CDC is supported in terms of getting. Our hope is that all public health agencies, despite how bad a time this is for state budgets, this is a real opportunity for them to engage with the clinical community and to start getting the data from the electronic health records. And there's also a lot of standardization that there's been resources for, and I think an emerging sense of, look, folks, we got to do this. We got to We got to, if the health records and the providers are meeting these standards, we should be able to receive it according to the same standards. So I do think there's movement there. We have great leadership at CDC. We're working really well together, and I think we're gonna solve this one.